Thank you.
So let's move to our next guest speaker, Dr. Entela Shkodrani, Associate Professor, Clinic of Dermatology, University Hospital Center, Triana, Albania. Her expertise include advanced clinic expertise in dermoscopic evaluation of pigmented and non-pigmented skin lesions, early detection and diagnosis of melanoma and non-melanoma skin cancer, risk assessment and screening strategies for high-risk patients, digital dermoscopy and sequential lesions monitoring. So her topic for today is main fields of activity, dermoscopy and skin cancer. So let us warmly welcome Dr. Antilia.
Hello. I don't know. Hello, I don't know if you hear me.
Yes, ma'am.
Okay, if you see me also on the computer, no. Okay. Okay. Do you see what I shared?
Yes, ma'am.
Yes. Okay, thank you. Hello from Tirana, and thank you for your nice presentation. It's afternoon. It's almost 2:35 in Tirana. It's really a sunny day. I would like to thank you for your invitation and everything else. I'm sorry to say that my theme is entirely medical. I'm a dermatologist on the University Hospital Sector in Tirana. I'm just presenting something about dermoscopy, about skin cancer, but not just diagnosing and treating skin cancer, but about statistics, about data, and everything else. So let's move to my before I begin my presentation, I would like to give you some images, and I'm sorry for its content because they might be a little bit disturbing of what I'm talking about. I'm talking about skin cancer. This is skin cancer. Skin cancer is divided in two groups: in non-melanocytic skin cancer and melanocytic skin cancer. This is basic BCC. It's called BCC, basal cell carcinoma. And the other one is BCC of the nose, BCC of the lips, and BCC on the body. And the other type of skin cancer is melanocytic skin cancer, melanoma, lentigo melanoma, which is the most dangerous one. And you see the images: melanoma on the face, melanoma on the body. And what I'm talking about dermoscopy. Dermoscopy is a crucial tool in detecting skin cancer, and it detects skin cancer early and more effectively. But what do we have? We have that more physicians, not entirely in my country, but also in other countries, do not endorse the concept of opportunistic screening in their patients. And for this reason, dermatologists diagnose cases of skin cancer in advanced stages, and dermoscopy serves only to confirm the clinically established diagnosis. And due to the fact that we in our country don't have a national registry of skin cancer, and not all dermatologists perform dermoscopy, we just undertook a retrospective study of 1,000 patients who underwent this examination in a dermatological reference clinic here in Tirana in two different frame times. And here also are some cases in which we use dermoscopy. We use dermoscopy to diagnose nevi, melanocytic nevi, congenital nevi, and so on, to detect skin cancer, to detect other skin problems. And these also are some cases of melanoma. You see melanoma of the toe, melanoma of the finger, melanoma of the on the face. So what we did, This is what I told you about. We don't have a national skin cancer registry in our country. We have limits data collection. And what we also have dermoscopy. We have digital dermoscopy, and we have handled dermoscopy. Dermoscopy, let me say that is one of our main tool to improve diagnostic sensitivity for melanocytic and non-melanocytic skin cancer. But despite that, many physicians in Albania do not endorse opportunistic screenings. This is the study objective. We made this retrospective study, which presents a comprehensive statistical analysis of 1,000 patients who underwent dermoscopic examination in a reference clinic. The data set is divided in two cohorts. The first 500 patients were evaluated between the year 2009 and 2010, while the second group of 500 patients was assessed between 2022 and 2024. Analyzing these two distinct timeframes, this study aims to identify trends and shifts in the incidence of most common skin cancers, including BCC, CCC, and melanoma. Key findings include comparisons of skin cancer prevalence across the two periods, changes in the average age of diagnosis, and gender-based differences in skin cancer occurrence. This is our methodology. So, retrospective study on 1,000 patients in two cohorts in two different times. We analyzed other data like age, gender, diagnosis, lesion location, and the patient origin. Statistical methods, we used ANOVA, chi-square test, and linear regression. Okay. Before I go to the key findings of our study, I would like to say that which is the importance of this study and why we did it. First of all, we wanted just to understand the connections which may help improve prevention and treatment strategies for melanocytic and non-melanocytic skin cancer. Such knowledge is critical for refining screening protocols, enhancing public health strategies, and ensuring the healthcare practices that they must be adapted in the current landscape of skin cancer diagnosis and prevention. So, first of all, we have here some of the results here, but I would like to read them by my way. The average age of the patient is 44 years old. The average of the typic diagnosis is 1.56, and this shows that there is no more patients who do not belong to the category diagnosed with skin cancer. Okay, this is the age group versus diagnosis types. So what do we have? We have that age from this data. We have that age may be an important factor in the occurrence of development of certain types of skin cancer, including the most common ones. So this helps to better understand the relation between age and the specific risk of specific skin cancer diagnosis. The diagnosis of BCC and CCC appears more frequently in the age group 41, 60, and 61, 80 years old. So this is a very important result in our study because we all know that skin cancers develop mainly in most advanced ages. So we say that a person can have BCC or CCC in the early 60, 70, or 80. But we also saw in our study that we have younger patients diagnosed with BCC and CCC. So we have one patient who belonged to the age group from 0 to 20 years old, 6 patients from 21 to 40 years old. And then we see the larger number of the group patients who belong to category of the age group 41 to 60, and 61 to 80. So in total, we have 180 cases of skin cancer, from them 132 with BCC and 60 and the 56 with CCC. So the most common form of skin cancer here in Albania, at least in our study, is basic cell carcinoma. What about melanoma? Melanoma is the deadly form of skin cancers. We know that melanoma, if it's not diagnosed in the early phases of the disease, is a very dangerous skin cancer. It can cause even deaths in advanced stages. What we saw, melanoma, we diagnosed 66 cases of melanoma, which were considered such as after the pathological examination. So the cases we diagnosed with melanoma were confirmed through pathological reports. So we do not diagnose melanoma and say it is a melanoma because we see it only in dermoscopy and clinically. We diagnose melanoma and then confirm it by histopathological report. So all the 66 cases we diagnosed with melanoma are 66 cases confirmed with pathological histopathology. We use the linear regression model to assess whether there's an increase in age associated with an increase in diagnosed cases of melanoma in a group of patients. And we found that there is no statistically significant relationship between age and the occurrence of melanoma in this data set. Melanoma cases in the first period, 2009-2010, belong to the age group 61 to 80 years old, while in the second group, 22-24, belong to the age group 27 cases. To the age groups 21 to 40, 7 cases of 6 were females and 1 male were younger than 30 years old. So this is an important data because, as I told you, we are used to get skin cancer in advanced ages, especially melanoma. But what we see that we have melanoma even in group ages younger than 30 years old. So we can say that there might be many factors which can contribute in this number of melanoma in younger ages. Maybe genetic predisposition, maybe even burns in the early childhood, maybe the way the skin was protected through the childhood, etc. So there are many factors influencing in this number, but this data can make us think and be careful for the future, because we just have to control our nevi. We just have to make regular appointments to our dermatologist and to see if we have dysplastic nevi, or if we have something new in our body, something new in our skin. Regarding the correlation between actinic keratosis and age correlation, what we saw, actinic keratosis is a predisposing factor for squamous cell carcinoma. So individuals in an advanced age have many actinic keratosis, which untreated can proceed in squamous cell carcinoma. What we found? We found that there is a strong correlation between age and actinic keratosis. This means that there is a slight tendency for actinic keratosis to occur more frequently in older individuals. What about the differences in age? What we found? We found that in total of all our cases, 425 were men and 575 were women. So diagnosed with skin cancer were women, 2 almost 40%, and men 51%. So we may say that in comparison with the total number of women and men, we see that 40% of our women and 51 are men. So there are more men affected by skin cancer. Maybe the way they expose themselves to the sun, maybe their occupation. There are many factors. I'm not discussing here the factors, but we found more men just affected from skin cancer. What about the location of the melanoma? We found nodular melanoma on the face. We found much cases of acral lentiginous melanoma on the hand. We found also melanoma. Just a moment, please. Lentigo maligna melanoma also on the face. We found superficial spreading melanoma located on the extremities in the lower extremity, and also we found a case of amelanocytic melanoma. Is very interesting because amelanocytic melanoma is a melanoma without color, without pigment. So this was a red spot localized all over the body, in the body, without any complaint, without any burn, without itching. It was a melanocytic melanoma, with its very most dangerous form of skin cancer of melanoma. Regarding the results by time period, in 2009-2010, we have melanoma cases mostly in the age group 61 to 80. In 2022-2024, melanoma cases shifted to 51 to 40 age group. And what about the gender? Melanoma cases under 30 years old, from which 6 female and 1 male. What can I say? First of all, that we have a very important tool. We as dermatologists, we have dermoscopy. We have also digital dermoscopy. On these days, we have digital dermoscopy with AI, so we are very much equipped. We can diagnose skin cancer early. We can catch skin cancer and melanoma in early stages, and this can help our patients. This can help patients to save their lives, because melanoma is one of the most deadly forms of cancers in all over the body, especially melanoma in the lower extremities, melanoma of the hands, of the fingers, melanoma, subungual melanoma is also a very deadly form. So we may say that dermoscopy is a very important tool in our hands to diagnose skin cancer. Age plays a crucial role in the occurrence of skin cancer. So we see that mostly skin cancer, BCC and CCC, are mostly related with age. What do we have? We in Albania, we don't have a national skin cancer registry, and this leads to underreporting. We really don't know statistically how many cases of skin cancer we do have, because many cases of skin cancer and melanoma are not reported, not by the public hospitals, but by private clinics and by private hospitals. There is no rule to report skin cancer and melanoma. What else can I say? That global studies are showing a rising incidence of skin cancer. White individuals between 65 and 79 years old have the highest increase in BCC and CCC. And what else? We need for routine skin examination in elderly patients. As a conclusion, I may say that dermoscopy is a very important key tool in early skin cancer detection. Opportunistic screening should be encouraged in Albania and in other countries, and because family doctors do not encourage opportunistic skin cancer screening. Family doctors diagnosing a patient, whatever might be the pathology, when sees something that is not right in the skin, when sees a black spot, a pigment, a red spot, must encourage the patient to visit and to diagnose this element, and also to encourage to make opportunistic screening. So they must make routine checks with dermoscopy to the dermatologist. Continuous monitoring of at-risk individuals is crucial. What does it mean? If you have so many dysplastic nevi, if you have so many nevi in your body, if you have an anamnesis of BCC, CCC, or melanoma in your family, if you have an important occupationals in the sun every day, if you have had a skin cancer in your body, you must be monitored to your dermatologist as protocol rules. What else? We had just made, let me say, a study just in one clinic, 1,000 patients. We know that it's a very small number to rule, but larger data sets needed to confirm findings. And we hoped we gave a little bit of contribution to our statistics in our country, just to show the trends and shifts of skin cancer in our country into different periods: 2009, 2010, and 2022, 2024. What do we recommend? We recommend to establish a national skin cancer registry. We recommend to improve public awareness and screening programs, to provide better training for healthcare professionals, but not only dermatologists.
Hello.
Men-
Ma'am, sorry to interrupt. Because of time constraint, can you please wrap up your presentation?
Plan systematic screening in geriatric care. I've finished. Thank you very much for your attention.
Thank you so much for that knowledgeable presentation, ma'am. Thank you so much.